Hello, everyone. Good morning for those of you not on the East Coast. Good afternoon for those of you on the East Coast. Thanks so much for joining us today for this webinar. So I'm Julia Resnick. I'm the Senior Director in the Department of Health Outcomes and Care Transformation here at the American Hospital Association, and I will be your moderator for today's webinar. Before we get started, just a few housekeeping notes. It is August of 2025, so by now we're probably all fairly familiar with Teams, but I want you to know that there's a chat function and a Q&A function. So at the end of the hour, we'll have some time to ask our panelists questions, but you don't have to wait until the end of the hour to ask those questions, so you can drop them in the Q&A pod, and we'll keep track of them and make sure to ask them in a little while. Towards the end, we'll also ask you to fill out an evaluation form, and we find that these are incredibly helpful for us as we develop future content that we want to make sure is useful to all of you. So let's get started. So welcome to the very first webinar of the Better Health for Mothers and Babies webinar series. So a little background on our initiative and to help ground us in the same information. We all know that despite medical advances, there are just too many women in our country who are injured or die from pregnancy complications. And those numbers are kind of stark. So each year, more than 50,000 women experience severe maternal morbidity. And we know that maternal mortality rates have doubled since 1987 in the US. And this is in stark contrast compared to other developed countries who have seen decreases in maternal mortality rates. Losing just one life is too many. And here at the AHA, our goal is to ensure that all women experience a safe, healthy pregnancy and birth. But what gives us hope is that we know that 80% of pregnancy-related deaths are preventable. And US hospitals and health systems are working towards solutions and strategies focused on saving as many lives as possible. So through the AHA's Better Health for Mothers and Babies initiative, we are working alongside our hospitals and health systems to help mothers and their babies thrive. And our shared goal, and I'm sure that one that you all agree with, is that we want to eliminate preventable maternal mortality and reduce morbidity related to pregnancy and childbirth for everyone. So the Better Health for Mothers and Baby initiative is guided by 4 core principles. We think that as you're thinking about your maternal health strategy, ways to incorporate all of these will be incredibly helpful to bring that to life. So those 4 core principles are examining quality and outcomes data to guide your strategy, considering and acting on the causes of disparities in health outcomes, engaging patients and communities, and of course, engaging an interdisciplinary workforce. But today we are just focusing on that first principle, quality and outcomes data, but not to worry, we have 3 more webinars coming that will each touch on one of the other core principles. So make sure you stay tuned and join us for that. If you go to our website, which we have linked elsewhere in this slide deck, we have a number of tools in our toolkit that can help you with your maternal and child health strategies. One comes from our discussion guide, and this one is from our action plan. So this piece thinks about the actions that you should be thinking about taking to reduce maternal morbidity and mortality. And for those of you who are still engaging in the process, we have this wonderful discussion guide that you can take to your providers and your communities and your leaders to talk about how you can better incorporate your data quality and outcomes to help you guide your strategy and have those conversations as part of the team. So you don't want to listen to me talk for the rest of the hour. We're here with 3 fantastic experts in the maternal health space. We have Dr. Catherine Glazier from Tuba City Regional Healthcare Corporation, Vicki Bukta from the Arizona Hospital Healthcare Association, and Lauren Russell from Regional One Health. So with that, I'm going to turn it over to Vicki, who's going to ground you in what's happening in the maternal health world in Arizona. So Vicki, over to you.
All right. Thank you. Hello, everybody. As was mentioned, today is the day we're going to talk about data and how we use data to improve maternal health. Next slide. I have nothing to disclose. Next slide. And I do want to let you know that the work that we're doing here in Arizona is a partnership between the Arizona Department of Health Services and our Arizona Hospital and Healthcare Association. Next slide. So in Arizona, we do have some objectives. We I will today talk a little bit about our rationale for the call to action here in Arizona based on our data. I'll identify the data elements we use to measure progress, and then I'll talk a little bit about the patient safety bundles that we are implementing, although Lauren will go into that in a little bit more detail, so I'll just touch on that. But definitely we'll talk about how we use them to improve care and reduce disparities. Next slide. So in Arizona, in 2011, we convened our first maternal mortality review committee. That was the first time we actually looked at the deaths in Arizona due to different various reasons. And we found that 89% were preventable at that time. You'll notice that in the introduction, about 80% are found to be preventable nationwide, but in our state, actually even more than that. And we did a deep dive, did a report to the governor's office, and in 2019, some legislation was passed to address preventable deaths. Next slide. We also took a step back and looked at some very high-level data, and I'll just share these with you so you can see what our thinking was in terms of how we started tackling this problem. So when we looked by race and ethnicity at severe maternal morbidity, which are those really severe outcomes, not necessarily mortality, but really severe outcomes, we had severe disparities. And you can see that the American Indian or Alaskan Native population had at least 3 times higher rates per 10,000 population than our white and non-Hispanic population. Next slide. And the same held true for our rural communities. So we had much higher rates of severe maternal morbidity per 10,000 deliveries in rural settings. Next slide. We also looked by payer type, and we saw that despite a small portion of delivery hospitalizations, really less than 1% of delivery hospitalizations in the Native American communities, the severe maternal mortality rate was highest among those whose primary care was Indian Health Services, which about 339.3 per 10,000, which was greater than 3 times the other payers. Next slide. So we then looked at the different conditions that were contributing to severe maternal mortality as well as morbidity. And we saw that the cardiovascular complications were the biggest bucket. And when we sliced down from there, we saw that hypertension and hemorrhage were really contributing about equally to maternal morbidity as well as mortality. But when we dug a little deeper, we saw that the cases of maternal morbidity related to hypertension were actually increasing at a greater rate than live births in Arizona between that time period of 2016 to 2019. And we were also encouraged by the CDC, and they were one of our funders, to look at hypertension. Next slide. Which in 1 year alone, there were about 2,600 hospital births in Arizona with severe hypertension. So just to give you a framing as to the size of the problem. Next slide. So we convened the Arizona Alliance for Innovation on Maternal Health, which is AIM. That's what AIM stands for, collaborative. That is a national initiative that has been going on for a number of years. It was started by ACOG, and Arizona officially joined in 2020. The goal is to reduce maternal morbidity and mortality through the implementation of AIM maternal safety bundles in participating birthing centers and reducing variation. The safety bundles are a set of evidence-based interventions for a specific population and condition when implemented together that produce a better outcome. And by everybody working on the safety bundles with the same intervention and reducing variation, we saw that we could also reduce disparities by standardizing care. It's really important to standardize certain elements of care. And then the ultimate goal is to use data to drive improvement. Next slide. So data are critical to identifying those quality improvement opportunities, as well as driving process improvement and technical assistance, and that's really where our association comes in. And then helping to evaluate QI activities and programmatic goals. And as we kind of pan out again, that's where our association comes in with keeping an eye from a statewide perspective on the data. Next slide. We also sliced our work as well as our measures by structure, process, and outcome. And those of you in the quality are very familiar with this. Structure would include things like policies, procedures, protocols. So when it comes to something like hypertension, do we have policies and procedures or protocols in place? Do we have process measures where we can actually look at the implementation of specific elements of these safety bundles? And then outcomes. So when we ultimately we want to make sure that we are improving maternal morbidity and mortality. And we know that what gets measured gets managed. So if we have the data, we can tackle it. Next slide. So we set very focused goals for hypertension. We learned from other states about what they were doing and emulated some of them, particularly California and Illinois, who were wonderful colleagues in helping us set these goals, and learned from them that reducing time to treatment is absolutely critical. If we did nothing else, that would be the one thing to do. So we really focused heavily on that. We did have a number of goals, but we did focus on, we wanted 80% of women who had 2 consecutive blood pressures of either 160 for systolic or 110 diastolic to be treated within 60 minutes. And then we wanted provide, if that goal was not met for any individual case, we wanted to encourage debriefs between the provider and the registered nurse so they could talk about why the person wasn't treated and then hopefully have improvement in that in the future. Next slide. So we collected baseline data and we brought our hospitals on initially with a kickoff, collected baseline data, and we set our goal at 80%, as I said, for time to treatment. And our initial measure, we were at 6% of people being treated in that time frame. And we set a goal for 50% for debriefs, and we had about 7%. We had debriefs happening about 7% of the time. So you can see we had quite a ways to go in terms of meeting our goals. Next slide. We provided lots of support, and this actually could be a whole nother talk about what we did to support our hospitals, but not only did we do a kickoff with speakers, and you'll note that we kicked off with hospitals in April of 2021, which we were in the midst of COVID. Hospitals were stressed, everybody was working very hard, and yet we had huge commitment from our hospitals as well as from our steering committee to keep moving forward with this because it was so very, very important. So we did kick off virtually and hosted, after the kickoff, we did monthly coaching calls where we encouraged our hospitals to talk to each other about what they were learning through these processes, particularly the PDSA cycles they were doing. We brought in subject matter experts and held health equity trainings. We provided one-on-one technical assistance to each participating hospital. And then to pan out a little bit, we did quarterly data infographics for hospital C-suites as well as maternal health leaders. And we continue to provide those today, as well as maintaining a data dashboard for hospitals to monitor their progress in real time. And then we had the opportunity to host 3 annual conferences for maternal health, providing education with wonderful speakers and vendors and networking opportunities. Next slide. I'll just take a moment here to talk about this one because we had one hospital in particular that they felt that they were doing absolutely everything right, and yet they were continually falling out on their time to treatment. And when talked to their hospital leaders that were participating in the AIM program, they said, well, their physicians had their own criteria for what would count as time to treatment and what a fallout would be. And we saw that they were not performing as well as they could be. And so you can see here, it's the 4th bar from the left with the arrow above it. I actually created a slide and from the National AIM database, and with this comparison of all of our Arizona hospitals, and called the chief nurse and talked with her about the patient safety bundles, about the importance of making sure that patients were getting evidence-based care. And she really took that to heart, and within 1 month brought their nursing staff as well as their physician staff along, so that they were almost at that 80% of the goal of 80% for treatment within a month of that conversation. Next slide. So we have been at 80% for treatment for over a year. As you can see here, we started out in April of 2021 at that 57%. And then for the 4 quarters of 2024, we were above 80%. Next slide. And the same thing for debriefs. For the whole year of 2024, we were above our goal of 50%. Next slide. So we did go ahead and decided to retire the formal requests that hospitals submit data for hypertension, although we continue to work on improving the care of people with hypertension. But we are actually going to repeat this process now, and we are implementing the hemorrhage bundles, and then moving from that, we will move into maternal mental health as well as substance use disorder. And we're doing many of the same interventions with the hospitals, including site visits, education, simulation, one-on-one coaching, and providing resources to the hospitals. Next slide. And with that, I'll turn it over to Dr. Glazier, who'll talk about implementation at one of our rural and tribal facilities. Thank you.
Good morning or good afternoon. Thank you so much for having me here. As has been said, I am Catherine Glazier. I'm an obstetrician gynecologist at Tuba City Regional Healthcare Corporation. For my disclosures, I have no relevant financial disclosures or conflicts of interest, but obviously I'm employed by Tuba City, and I'm also a member of the Arizona Maternal Mortality Review Committee. For learning objectives for the brief part of my conversation are to review hypertension as a cause of maternal mortality in Arizona, review our experience with treatment of hypertension in a rural indigenous community, and to recognize a few challenges in implementation. So as Vicki has already said and referenced, we have I'd say a robust maternal mortality review committee in Arizona. And this slide shows data from the most recently published reviews and demonstrates that cardiovascular conditions are the second leading cause of maternal mortality in Arizona at 20.9%. And of course, cardiovascular conditions, as demonstrated on the slide, include a number of different entities, but also hypertensive disorders of pregnancy. This is again another bit of data taken from the most recently published report in Arizona. And the top group is American Indian or Alaska Native people. You can see with the first sort of light purple bar that they are 5.8% of births in the state, but for pregnancy-associated deaths, 15.1% of those deaths. The pregnancy-related deaths are suppressed because the number is quite small, but the point of this is that obviously, as Vicki let you know, the severe maternal morbidity is out of proportion to the percentage of birthing people, as are the pregnancy-related deaths and pregnancy-associated deaths. So one of the recommendations at the end of that report by the committee was to increase education and awareness for both clinicians and for family members around these causes of death. So this AIM bundle really speaks to that. Now, our experience in Tuba City is what I want to share with you now. And this is a picture of one of two multi-story buildings in Tuba City. Tuba City is really more of a town. You'll get the idea. And this is our outpatient clinic in one of the newer buildings as well. So our hospital is a licensed 73-bed hospital on the western edge of the Navajo Nation. It, as part of its mandate, cares for birthing people of the Navajo, Hopi, and San Juan Southern Paiute tribes. And we have approximately 350 to 400 births per year in most recent years. This is a picture that I've borrowed from the New York Times. This article is about 10 or maybe more years old now, but it was an article that talked about our trial of labor after cesarean program. And the photograph is nice because it shows a Hopi family in a ceremony at sunrise shortly after the birth of their child. And you can still find the article if you want to. So we are a collaborative team of both certified nurse midwives and obstetrician gynecologists. Our labor and delivery unit is always staffed by the certified nurse midwives, and they have consultation provided, obviously, all the time by OBGYNs as they need. We already had a baby-friendly certification when we started our journey in the AIM bundle, but we also know that 20 to 30% of our patient population in pregnancy either has gestational diabetes or pre-existing diabetes. 80% are overweight or obese. So these are some of the challenges we know we face. I showed you the picture of the 3-story building. Our hospital is right next to that, so that is an advantage, I think, for us that all our services are at the same site. So the picture is of a dinosaur track, which you could see right outside of Tuba City, but kind of represents our journey with the AIM Collaborative. As Vicki mentioned, we were one of the original hospitals joining in April of 2021. And as we started the journey, we already had in place drills, case reviews, and an order set to treat hypertension in our electronic health system. And we were also members of the Arizona Perinatal Trust, our quality collaborative in the state. But new things for us included the AIM bundle's mandate for required training about hypertension, and then, of course, that measurement of the 1 hour to treatment, as well as the debriefing. The AIM bundles, if you've implemented, you also know that they encourage you to have training in equity and diversity, and that was a new thing for us to have formal training in that. And then not required by the AIM bundle, but an additional step that we took was to distribute blood pressure cuffs through a series of grant funding. For many of us, a blood pressure cuff isn't that expensive, but the cost can be prohibitive to some members of our community. This is the card that we gave patients when we gave them the blood pressure cuff. This was also designed. We have a great team that designs a lot of social media and other things for us. I did not do this myself. So it gave instructions for the blood pressure cuff and also numbers to call with any questions. Excuse me. So as Vicki shared a slide with you about another hospital in the state that had room for improvement. This shows our treatment of hypertension in 2024. And Tuba City is the bar to the side that has 100% of treatment within that 1 hour goal. And we're one of the less than 500 birth hospitals, so represented by that purple bar. This is our overall data showing our failures and successes since implementation. So the purple line shows patients treated within 60 minutes. And you can see that usually we were able to do that 100% of the time, but we did have a couple fallouts, which are shown in the fourth quarter of 2022 and the fourth quarter of 2023. But once we implemented the goal of debriefing, we were able to meet that goal. So we were able to learn from our fallouts, whereas in the past, we might not have recognized them. One was when we transitioned our medication storage from Omnicell to Pyxis, the nurse had some difficulty with the new system and wasn't able to get the medication out in a timely fashion. So you can definitely learn from that. And then we also noted that we had fallouts occasionally during procedures. So for us, of course, that's a patient receiving an epidural during the course of labor. And we saw that at times those blood pressures weren't attended to in a timely fashion during that. But one of the things that has made the success in some way easier for us is that we are all employees. So we have policies and guidelines which we follow, and a person doesn't get to assert sort of their own beliefs about anything. We follow the rules that we set for ourselves. So opportunities for us as we move forward for this, we've implemented the hemorrhage bundle. This is something that we deal with quite frequently in our patient population, so we get a lot of opportunity to engage with this. So we've done this. The substance use bundle has been more difficult because this includes people outside of our unit. So this has been, it has required a great deal more collaboration. And our next goal is to implement the sepsis bundle, though we have policies around sepsis already. Any implementation of any of these bundles gives you an opportunity to look at what you're doing well and what you can improve on. And then lastly, and this came up fairly recently, we realized that though we have updated policies for both nursing and clinicians, some of our clinicians were accessing an old binder of guidelines. So this caused some conflict. And this, we also could see that this was an opportunity for us to improve. So I will stop there, but thank you so much.
Hey everyone, good morning and good afternoon. My name is Lauren Russell. I am the Director of Women's Services and in Memphis, Tennessee. I have the privilege of working at Regional One Health. Here at Regional One, we specialize in complex OB care for moms and babies. We have a level 3 NICU. We are a 15-bed unit with 9 OB/ED beds. We deliver about 2,300 babies a year, and we see about 6,000 triage patients a year. So both our triage and our labor and delivery remain pretty busy. I also have the privilege of serving on our maternal mortality review committee here in Tennessee, and I did pull this from some of our state statistics. In looking at our 2024 annual report, we noted that 76% of pregnancy-related deaths were preventable in 2022. And we also see that our cardiovascular conditions accounted for 22% of those deaths. The leading cause death among non-Hispanic Black women and women 35 years age and older. And so we wanted here at Regional One to partner with our state to see what we could do moving forward to help improve some of these statistics. So here in Tennessee, we have the distinct privilege of having the Tennessee Initiative for Perinatal Quality Care. We call it TIPQC. This is our state's perinatal quality improvement collaborative that we work with. Hospitals all across the city gather together, and usually we pull those AIM bundles, and we work on this as a whole state. We've been doing this for 17 years. We have quality improvement projects, education, and trainings across Tennessee. We recently were privileged to host one for our region here at Regional One recently. And we did a maternal code event and just get these nurses practicing what it feels like and what it looks like, and looking at some of the structure of ensuring that we're providing quality care to our moms. We also have a shared governance that relies on statewide engaging of both nurses and providers to look at that care and make sure that we're driven by our quality and our data. We have a robust centralized project management system and data support that includes RedCap and Vaughn for our NICU folks, and then AIM, and those are the drivers that we're using. So we want to look at our model for improvement. What are we trying to improve? How will we know that change was an improvement? And what can we do with those change results? And so this is our PDSA cycle that we're going to talk about in what we did here at Regional One. So we too committed ourselves to reducing the rate of severe morbidities in pregnant and postpartum women with severe hypertension by 20% by December 2021. And so we looked at treating those moms within an hour that fired off those 2 blood pressures. And then what were we going to do about that? So we wanted to look at all mothers during their birth admission, and that even included ectopics and miscarriages. So we looked at every patient, every birthing person that came through, preeclampsia cases, severe preeclampsia, eclampsia, and then your superimposed preeclampsia on all of your mothers. So what were our metrics? What were our project measures? We had safety drills, we had provider education, we had nursing education about the treatment of severe hypertension. So our problem is, how are we going to get these moms treated? And our solution was, we created a nurse-driven protocol. So we created this nurse-driven protocol that said, if then. We put this protocol before our physicians, we voted on it, we were able to load it into Cerner so that if a patient comes in, maybe she's scheduled for an induction and she's just here not through triage, or maybe she comes to triage to be evaluated for labor. If she meets that criteria, the nurse-driven protocol says without special orders, this is a standing order set, the nurse can put that order set in and treat her immediately. So my favorite part about this protocol is that not only did we meet the metric of getting those patients treated, we empowered our nurses to use the tools before them to ensure good quality care for our moms. So some of our structure measures, we talk to our patients, our family, and our staff. We have those specific resources and protocols developed. We did our debriefs. When we were missing our metric, what did we do about it? Why did we miss our metric? And we talked about some ways that we can improve. We have multi-D case reviews where we get in bunches of groups together, our pharmacy folks, our case management folks, our nurses, our doctors, our church nurses, making sure we're coming together and reviewing how we can improve. We have unit policy and procedures. We have a severe hypertension preeclampsia policy that guides our care. And we've integrated all of this in our electronic health record, and specifically this order set, which we'll talk about next. Okay, so here is our OB severe hypertension pathway order set. This is a power plan. We are a Cerner shop, so that's what we use. The nurse confirms her severe range blood pressures greater than 160 or greater than 110, 2 times 15 minutes apart. And I will tell you, just this month, we have gone back and amended this protocol and said that it can be 2 times in an hour. It does not have to be consecutive for us. So we'll go back and update these slides. We actually met yesterday and wanted to clarify that language so that we can make sure that we're capturing and we're treating all these moms that are meeting this criteria. So the nurse initiates the severe hypertension nurse-driven protocol, and she can treat her patient in one of 2 ways. She can give her 10 milligrams of Procardia, PO immediately. We have that readily stocked in our Omnicell. It's easy to access. And then she calls her provider and says, hey, I've initiated the protocol. What do you want to do next? And then we're rechecking those blood pressures. But better than that, we have a significant portion of our patients that come to our hospital by ambulance, and they already have IV access. If those patients have IV access, per the protocol, we can give them 20 of labetalol IV. So you have a PO dose and you have an IV dose to make sure that your patients are intervened quickly and timely in the best way possible. If after dosage and after 20 minutes, because remember this is the 10 of the fast acting, she can give 20 milligrams of Procardia PO, recheck that blood pressure, and if it's resolved, we're going to go to every 10 minutes for 30, and then we'll get her back on a 30-minute schedule of checking her blood pressure. Per the pathway, we're going to discontinue that pathway 4 hours after that initial dose. And if she fires off more blood pressures that fit your severe range criteria, we're just going to start the protocol again. So again, there's that opportunity to really empower your nurses to say, if I see it, I can treat it through this protocol. They don't have to track a doctor down. Here at Regional 1, we're a teaching facility, and what we find is that a lot of our doctors can be all in the OR or all in a delivery. And maybe you're struggling to find a provider. You can cut down that lag time. These nurses are driven and they know how to respond with this protocol because they feel empowered to treat. This is through ACOG. This is the labetalol protocol. There's also a hydralazine that we have since phased out, but we're using this IV labetalol protocol and also this Procardia protocol. So it gives you an algorithm of how to go through, and it makes it really clear. We have these posted all through labor and delivery. We have them posted all through OB/ED, and we have them posted all through postpartum to make sure that our postpartum nurses also feel empowered to treat these patients postpartum, because we know that this treatment goes beyond OB/ED. It goes beyond their initial visit to triage. And it also goes beyond just labor and delivery. We have to get these moms treated through their whole phase of care. So we have the privilege here at Regional One. We have a great professional development department, a great education team, and they created this pathway, this color-coded, just easy to look at, easy to remember. This pathway is also posted everywhere for all the nurses to see, and we're really driving them to initiate that OB protocol and treat their patient appropriately. Last but not least, this was our end of quarter sampling for 2025. And I'm happy to say that we treated 100% of our moms. We are doing really well with empowering these nurses to respond appropriately. I'll tell you, one of my favorite things to empower these nurses and to talk to them about this protocol is I compare this protocol to CPR. If you were to find your patient in cardiac arrest, you wouldn't go to your doctor and say, hey, do you want me to start CPR? No, you'd act, and you'd act fast because you're empowered and you know what to do. We have to really change our mindset and change our conversation and the verbiage and the urgency in which we're talking about treating these moms. This is not benign. This is not just an antihypertensive. This is treating these moms to save their life. And we're really talking about cutting down that morbidity and mortality of these mothers. So I think it's important for us to change the conversation. It's not just blood pressure medicine. It's life-saving treatment. I'll be honest and say one of the barriers that we continue to face sometimes is that we're a teaching hospital. We have residents everywhere. And occasionally, especially around the summertime, when we rotate those residents, we have residents, just like Dr. Glazer said, that occasionally say, well, I'd like to do it this way. But that's where we empower those nurses to say, no, this is what we're going to do. This is the protocol. Especially our new folks that are just coming in and kind of getting their footing and learning how to communicate well with their doctors, learning how to assert themselves in an appropriate way that says, hey, this is the protocol. This is what we're going to use. Let's do this together. So thank you for listening. I really appreciate it.
Wow, that was fantastic. Thank you all for sharing the work you do, and more than that, the work you do to support your patients and your communities. It's so important, and you're clearly saving lives by using your data to drive your quality improvement efforts. So as a moderator, I have a little bit of moderator's prerogative to ask some questions, but I want to encourage all of our participants to chime in through either the chat or the Q&A box with their questions, and I will pose those to our speakers. But to start, there's this theme that I've noticed throughout all of your presentations, and it's really about like you have these patient safety bundles, which you can see in a checklist. You see how to do that, but like to bring them to life, you really have to figure out how to integrate them into the workflows. So from your experience of doing this work, like what does it take to take the bundle on a page and turn it into like a sustainable change in how your care teams are providing care to your patients?
Yeah, I'll start first. We really have the privilege of partnering with TIPQC, that organization, through our state. They are so supportive in trainings, in providing those resources. But here inside Regional One, we have some leaders that are focused on quality and focused on that data. And when you have a quality and a data focus, it's hard to not make sure that change happens. When you're getting the buy-in from your team, we also have that great professional development department that I talked about. And we just commit to the education never stopping. We commit to collecting that data. And when we see fallouts, we talk about what happened. We talk about fixes. And we just really never take our eye off the prize of what does the data say. Because when we're talking about that data also transforms into healthy moms and babies in our community. And we remember that those numbers are reflective of moms and babies. It's hard not to stay focused.
I would agree with what Lauren said, and I feel like since I was a resident, there's been sort of a paradigm shift in that we don't think as much about the hypertension and trying to rationalize why it's there. So we don't think, well, she was in pain, or maybe she had some other thing going on at this time. We just begin to treat it when we see it, like Lauren's empowered her nurses to do. So I think for our clinicians, because we're always there, we don't really have to be found. It was just a shift for us as well, that paradigm shift, that we didn't try to think too much about the hypertension. When we see it, and we see it more than once, we just move to treatment. And that is our new way of thinking about it. And the bundles really help you to kind of solidify that.
Yeah, and I imagine that as you're thinking about implementing other bundles or other quality improvement initiatives, it's really that same, just flipping that switch and knowing your workflow. So I want to pivot a little bit to something that Vicky alluded to, but it's one of the things that I've been particularly interested in. And that's, when you're looking at AIM bundles and you're looking at these perinatal quality collaboratives across the country, no two of them are structured the same. And Arizona is a little bit unique in that you run the PQC through the State Hospital Association. So how do you see, for states where that is the case, how do you see the State Hospital Association being able to support hospitals in these efforts? And for ones where the PQC may be run differently, how can the State Hospital Association, the hospitals connect on improving quality outcomes?
So thank you for the question. I will clarify first that we are not the PQC. Dr. Glazer mentioned the Arizona Perinatal Trust. They are the PQC for our state. And there's a little bit of history there in that while they are the PQC, at the time that the AIM initiative was coming about in 2019, 2020, they were not in a position to really run the quality collaboratives. And so our Department of Health Services turned to us as the Arizona Hospital and Healthcare Association to say, you're really good at running quality collaboratives, and that we have a history of running collaboratives and with great outcomes. Would you be willing to run this one? And we said yes. And even though I, for example, do not have a background in maternal health, what we're good at is bringing people together, having everybody's voice be heard, helping our hospitals share with each other and learn from each other. So and we don't have to be the subject matter experts, but we tee up the data, we tee up the teams and really bring them together. And I think anybody in that position could do that. It's a hospital association is a sort of a natural fit, I think. But if the hospital association is the PQC, then it's even better. But as Lauren talked about, you can work as an individual facility and work with your PQC or work with your hospital association.
Absolutely. So as you're thinking about improving care and improving outcomes, we know that patients are only in their hospitals and are only having contact with you as their providers for this short period of time. And there's so many other partners, stakeholders in the ecosystem. So how are you thinking about partnering outside of hospital walls so that they're getting great prenatal care and getting both great postpartum support to help improve outcomes?
Well, for us, I will say we've had partnerships from the very beginning. So I mentioned that we formed a steering committee in 2020 before we launched, and with about 40 individuals, which included hospital leaders and community physicians, but also our colleagues from the March of Dimes, Postpartum Support International, Fourth Trimester, and all of those community organizations that could help us identify before we see the patients in the hospital and then also after.
Right. Lauren, Catherine?
So yeah, we have the distinct privilege of having a grant here at Regional 1. It's called the Maternal 1 model. Through that Maternal 1 model, we are helping our moms. So here at Regional 1, we serve primarily Black and Brown moms with low levels of access to care. But beyond the low levels of access to care, our moms are struggling significantly with resources, whether it be housing, whether it be transportation. And so through our Moms Grant, we are helping our moms with housing and transportation and even food, the basics that these moms need. We want to make sure that our moms are eating well during pregnancy, because how do you have a healthy pregnancy if you don't have a healthy body weight? If you're not consuming the protein and the fats and the carbs that you and your new baby need. And also sometimes that food is also translating to other children in the home. We've got to make sure that our moms are getting their basic needs met. For our moms that are struggling with housing, we have a program that we're hoping to supplement them. For our moms that are struggling with prenatal care, we find so many times our moms want prenatal care, but they really struggle with transportation. Here in Memphis, our buses sometimes can be really unreliable, and you might take 3 or 4 buses just to go a few miles. When you're a young mom that has other littles with her and you're pregnant, and here in Memphis right now, it is 1 bazillion degrees. Waiting at a bus stop can really be a barrier, and you just say, hey, I just can't do it, or this just feels like too much. So through this grant, we're just making sure that these moms' basic needs are met. And we believe that those basic needs are going to translate beyond pregnancy as well.
Fantastic. And how about in Tuba City, where it's also probably a bazillion degrees?
Well, Arizona, of course, is like all Western states, fairly big. So the issues that we can see in rural areas like Tuba City can be very different than those in Phoenix or Tucson, which are the places in Arizona lots of people are more familiar with. But in Tuba City, as a tribal facility, we have the good part of that is that people are usually tribal beneficiaries, so their healthcare is a right through treaties, or they're covered through Arizona's Medicaid program with our Medicaid expansion, which happened quite a few years ago. So access to care, at least that part of it is covered. However, because it's rural and about 75 miles from other population centers, people can still need to travel a long way just to get the care. Of course, there's no buses, but there is transportation services that can, if you have Arizona's Medicaid, that can help you with that. People get other services and support. But in Phoenix or Tucson, despite the fact that it can feel like there's hospitals everywhere, there's also the issues of access through that. And of course, transportation, like Lauren said, it's a bazillion degrees in Phoenix and Tucson as well. Even though it's a dry heat, it's still pretty unpleasant to use a bus to get around. So I think we know our own systems and the challenges we face, but one thing that the maternal mortality, which of course is a review committee, which of course is looking at the most unfortunate cases, kind of helps us look at resources that might improve things in the rural area versus the urban areas.
Excellent. And I know we spent a lot of time talking about data, and data can get a little impersonal. So I want to shift to like the more personal side of this. So like how are you thinking about engaging the patients behind the data? And are there any stories that have resonated with you that you can share with this group?
I'll go ahead and jump in again. One thing that, the work with the review committee and the quality bundles has helped me to realize is that, as a physician, something you might see as a good day because you avoided mortality is still a really challenging and difficult day for the patient. And so I think that that's something that the AIM bundles have really helped us to shift, not just the debrief about delays in care, but debriefing with the patients and their families about any of these severe morbidity type of cases. I, as a younger doctor, I remember a patient coming to me and, she'd had complications in her care. I had seen her throughout her course up until the time of her delivery. But, things had turned out well despite those complications from my point of view. So to have her tell me how hard all of those steps were for her, I think it was the first time, that I had kind of shifted to realizing that, what's a good day for your doctor might be a really hard day for you. And that's been really helpful for me to see that way.
Profound perspective. Lauren, anything from you?
Julia, gosh, probably 10 or 15 years ago when I was at another institution and I was a bedside labor and delivery nurse, my friend and I cared for a mom, somewhat limited prenatal care, preeclampsia, on MAG, doing all the things. And she called out and said, can I get someone in here there's something dripping on the floor. And I turned to my partner and I was like, her name was Ruthie. I said, Ruthie, you're magging the floor, aren't you? And she said, oh gosh, I must have not done her IV lines correctly. And I went in and it was not the Pitocin or the magnesium. It was audible blood loss. She was hemorrhaging. We had just left the room 15 minutes ago, tucked her all in, all was well. It was audible blood loss. We pulled the covers back and there was probably 1 to 2 liters in the bed, and there was probably another 1 to 2 liters on the floor. And immediately, we actually just grabbed a stray physician in the hallway because her physician was in the OR. And we said, hey, we need help urgently. And she said, well, let's go to the OR right now. And my partner and I got her out, got her delivered. And she actually coded when we were in the OR, when we were able to get ROSC. Everything was stable. Baby did well. Mom did well. Mom was transferred to the ICU. And we went and saw her 2 days later, and she was doing wonderfully. She was just doing beautifully. And she grabbed me by the hand and she said, hey, you saved my life. Thank you. And much like Dr. Glazer said, that was my job. And I did my job well. But behind our jobs, there are patients and families that we are impacting with the care that we provide every single day. And honestly, she said, I kept, at the time of the event, I was shouting at my partner, Ruthie, let's go, hurry up. And she said, were you the one shouting, let's go so many times? And I said, yes, that was me. And it also reminded me that even in her time of distress, she was listening. She was listening to everything that we were saying. And so that patient has always stuck with me all these years later too. And I think about her a lot. Her and her baby went on to be discharged together. Everyone was well. But I'm thankful for call lights. I'm thankful for patients who were able to say, I need some help. I'm thankful for partnership in the hospital. And that's just one story of there's 89 people on this call. All 89 people on this call have 2 or 3 other mothers that they could say, I intervened, and sometimes it works out and sometimes it didn't. But those patients, you carry a little piece of them for the rest of your life. And so I think that's why we do this work, because we remember those moms and those babies that we care for.
Yeah, that is such a powerful story of why we do what we do and don't give up and try to make it so that any avoidable mortality or morbidity can be accomplished. So in the interest of time, I'm going to turn to some of the questions that are coming in, and a reminder, folks, that you should ask your questions. But I think this is a really important one about how do you feel that health plans and managed care organizations can help support your work, especially since we know that, making sure these services are paid for is huge to sustaining them in our hospitals.
Absolutely, making sure they're paid for. And we were proactive in Arizona by engaging the health plans early on, as early as we could, in our AIM steering committee. We wanted them to hear from the providers who were joining us, as well as the teams of people who were there, what the stumbling blocks were. So, for example, we really, really wanted all of our patients who were diagnosed with hypertension to be able to have a blood pressure cuff. And one of our Medicaid health plans said, well, that's not a problem. All they do is get a prescription and they can go down and, it's treated like DME. And what we heard from the patients was they're denied 100% of the time. And the health plan responded, well, the patients can just appeal. Well, pretty much you've lost everybody at that point, right? Like, they don't know about appeals. And then if you figure they're taking the bus to go to the place where they're supposed to get, they can't just go to the local pharmacy on the corner. They have to go to a certain provider for their DME. It was so very difficult. So we really tried to engage them in helping us work through some of those kinds of things by engaging them early in the process.
Fantastic insight. And on the data front, we have a really interesting question about hospitals that have relatively low volumes of severe maternal morbidity, and given that less a smaller population base, it's how do your teams approach analyzing those outcomes among smaller groups? And is there a role for linking longitudinal patient data? Basically,
Well,
what do you do with small numbers?
Yeah, I would tell you, first of all, on the longitudinal patient data, so the data that we have access to is we have numerators and denominators. We are not able to track and trend by patient at all. The hospitals could potentially do that, but we at the association are not able to do that. In terms of small numbers, you know, we really encourage everybody to try to hit their metrics, and it can look bad if they only have two hypertensive patients in a month and one falls out 50%. It's like, oh my gosh, that's horrible. But we really encourage them to look at every single case, and that's where the debriefs come in, and just learn from that and move forward.
As a small facility, that's what we've seen. Like we can't have statistical significance with our data, but each time we have a fallout, it allows us to learn from that. Yeah, because we're honestly, you know, with 30 deliveries a month, we might only have, definitely less than 5 that are getting treated for severe hypertension. But each time we have a case, when we're paying attention to it through this lens, we have a chance to learn from it.
And another question for the Arizona team. Did you have any providers who were hesitant to share their data? And if so, how did you overcome those challenges?
So we worked with the individual hospitals, and we initially approached it with the fact that they would be blinded. So they submit their data, and again, it's numerators, denominators, it's blinded. No one will know who's who. And so we did have a few hospitals that were a little, they wanted data use agreements and things like that. But we really have, through some pressure of everybody else is doing this, and you're like one of the last few holdouts, we got everybody on board, and we were really very lucky in that we do have a couple of IHS facilities, and they are usually a little bit more reluctant to share their data due to data sovereignty and things like that. But they even recognize, in the spirit of quality improvement, that there's really nothing that could come back at them in terms of, if they were to submit their data, it would all be protected, and that we would use it in the spirit of quality improvement. So we've really had very good participation.
It's wonderful. And I think, yeah, the key to it is it's not judgmental, and it's all in the name of quality improvement and getting the best outcomes. So I want to thank all of you for joining us. Feel free to reach out at any time. I specifically want to thank Catherine and Vicki and Lauren for sharing their expertise and their insights with us. This was fantastic, and really appreciate everyone's commitment to improving maternal health in our country. So thank you all so much, and have a great day.